Hello everyone and welcome to our module on skin infections. What we're going to do in this video is talk about skin infections, beginning with the most superficial infections and finishing with the deepest skin infections. So we'll start with impetigo, and the reason we're starting with impetigo is because this is a very superficial skin infection. It involves the epidermis, and in impetigo, bacteria get into the epidermis and neutrophils collect beneath the stratum corneum layer of the epidermis. The neutrophils and the bacteria lead to the formation of macules and papules, which can rupture and cause erosions. In addition, the rupture can lead to dried sebum on the skin, and this creates the classic so-called honey-colored crust of impetigo. This is a picture of a child with impetigo on the screen here. This disorder is common among children, and you can see that there's a honey-crusted lesion on the face. Impetigo is highly contagious. We'll talk about the bacteria that cause it in a minute. And this has implications for children because this often occurs in children. So if a child develops impetigo, that child has to be sent home from school and cannot return until he or she has gone to the pediatrician and been on antibiotics for at least 24 hours. There are two subtypes of impetigo. The first type is called impetigo contagiosa. It's also called non-bullous impetigo. This is the traditional and most common form of impetigo. It typically affects the face and the extremities, and it's caused usually by Staph aureus, but also sometimes by beta hemolytic strep. And by this I mean mostly strep pyogenes, which is group A beta hemolytic strep. And this form of impetigo leads to the classic honey-crusted lesions like we talked about on the last slide. The second form of impetigo is called bullous impetigo, and this form gets its name because in bullous impetigo, bullae form on the skin. This is a picture of a bulla shown on the screen here. It's a fluid-filled collection. Some people will simply call it a blister. This form is also seen in children. The trunk is more commonly involved in bullous impetigo, and this form is always caused by Staph aureus. Now, I told you that the traditional honey-crusted form can be caused by Staph aureus, and I also told you that this bullous form is always caused by Staph aureus. So why does Staph aureus sometimes lead to the non-bullous form of impetigo and other times lead to bullous impetigo? Well, let's talk about that now. Some strains of Staph aureus produce a toxin called exfoliative toxin. It's also called exfoliatin, and this toxin destroys keratinocyte attachments. The way it does this is by cleaving the desmoglein 1 complex, and it's high yield to remember this for step 1. This is a desmosome protein that links keratinocytes together. So when strains of Staph aureus produce this toxin, keratinocyte attachments get destroyed in the stratum granulosum. This leads to one layer of the skin detaching from another, and then fluid can fill in that space, and that's what leads to bullous impetigo. So the reason some forms of Staph aureus cause bullous impetigo is because of this toxin and because it destroys attachments in the stratum granulosum. This same toxin produced by some strains of Staph aureus can cause a problem in babies called the scalded skin syndrome. This is a newborn disease. When babies are born, their skin is colonized by bacteria. Remember, there are normally bacteria found on our skin. And sometimes babies are colonized with a strain of Staph aureus that produces the exfoliative toxin. And in this case, the toxin is produced diffusely all over the baby's skin. This classically occurs about 3 to 7 days after birth when babies are becoming colonized with bacteria. The baby can develop fever and then diffuse erythema, and the skin can begin to slough off. This is a picture of a baby with the scalded skin syndrome here. You can see that the skin is peeling or sloughing off. Now remember what I told you on the last slide. The damage in scalded skin syndrome, just like the damage in bullous impetigo, is intraepidermal. The toxin produced by Staph aureus is affecting the granular layer of the epidermis. What this means is that even though this looks scary in a newborn baby, the skin will peel off and then it will heal completely with no scar because the dermis and the basal layer of the epidermis remain intact. Babies with the scalded skin syndrome often have Nikolsky's sign. This is when the skin slips off with a gentle tug. This happens anytime layers of the epidermis detach from one another. You can basically pull the layers apart. The treatment in a newborn baby is with antibiotics, and like I said before, it usually heals completely with no scar. So just like bullous impetigo, the scalded skin syndrome is related to Staph aureus, and it's related to that exfoliative toxin destroying keratinocyte attachments. Now let's talk about the skin infections erysipelas and cellulitis. We'll talk about these together because they have many features that overlap. The main difference between the two is the layer of skin involvement. I'll talk more about this in a second. The way these infections usually develop is there's a break in the skin or trauma to the skin, and this allows bacteria to enter the layers of the skin. This causes redness and warmth, sometimes fever. Usually these are unilateral infections. That's because they're caused by trauma. So usually there's only trauma to one side of the body. They're very common on the legs and lower extremities because we often fall and damage the skin in these areas. In addition, erysipelas is common on the face. Erysipelas is an infection of the superficial dermis. So remember in impetigo, that was an infection of the epidermis. Now we're talking about infections of the dermis. And in the case of erysipelas, we're talking about the superficial dermis. This tends to affect either young children or older adults, and it's usually caused by group A strep or strep pyogenes. It typically has an acute onset. Patients develop fevers, chills, and rash signs of infection, and then they develop a red rash on their skin with a clear demarcation between the rash and normal skin. This is a classic feature of erysipelas. Here's a picture of a man with erysipelas, and note that there's this very clear demarcation between the red and infected skin and the normal skin. That's classic for erysipelas. It also tends to occur in older patients like this man. It also tends to occur on the face. So this is a classic presentation of what erysipelas can look like. Remember, it is an infection of the superficial dermis. Cellulitis is similar to erysipelas. However, the infection in this case is the deep dermis, not the superficial dermis. In addition, it can sometimes involve the subcutaneous fat. So remember that the layers of the skin are the epidermis, if you look at this picture on the bottom right side of the screen, followed by the dermis, followed by the subcutaneous fat. In cellulitis, we're talking about the deep dermis and the subcutaneous fat. This typically occurs in the middle-aged and especially the elderly. It rarely occurs in children. Many of your patients on the inpatient service in medicine will have cellulitis, and they are usually elderly patients. It's caused by group A strep, like strep pyogenes, and also sometimes Staph aureus. In contrast to erysipelas, this tends to have a slower onset. It doesn't have that abrupt onset with fever and chills. A slower onset of a rash, focal pain, and warmth over a few days. And then another classic feature of cellulitis that distinguishes this disorder from erysipelas is that the borders are ill-defined and they tend to spread out over time. Here's a picture of a man with cellulitis. Note that it's hard to tell precisely where the border is. There's some deep red over in this area here, and then it gets lighter, and then there's normal skin here. It's not as clearly demarcated as erysipelas. In addition, cellulitis tends to spread outward, so when patients are being treated, often you will mark the edges of the rash so that you can tell from one day to the next whether the rash is expanding or receding. Another skin infection that is related to cellulitis and erysipelas is a skin abscess. A skin abscess is a collection of pus. Pus is made up of neutrophils and bacteria, and in a skin abscess, a walled-off collection of pus develops in the dermis or subcutaneous space. This is usually caused by Staph aureus, and it leads to the presence of a red, painful nodule on the skin. The skin over the area of pus will be tense and raised. I'll show you a picture of this in a minute. And this often develops as a complication of cellulitis and erysipelas. You can imagine that if these processes lead to bacteria in the skin, that sometimes an area of pus can become walled off. And it's important to recognize a skin abscess because it usually requires incision and drainage. Antibiotics have difficulty penetrating the walled off area of the abscess. Here's a picture and a cartoon of a skin abscess. If you look at the picture on the left side of the screen, notice that the skin is raised and tense above the abscess. This needs to be incised and drained to let the pus out, and then the area can heal. So now we've talked about impetigo, which is a superficial skin infection involving the epidermis. We've also talked about cellulitis and erysipelas, which is an infection involving the dermis. Now we're going to talk about necrotizing fasciitis, which is the deepest skin infection. It's also the most dangerous. Necrotizing fasciitis gets its name because it's infection of the fascia. Let's look at this cartoon on the bottom left side of the screen here. We've got the epidermis as the most superficial layer. Beneath that is the dermis. Beneath the dermis is the subcutaneous fat, and beneath that we have muscle and deep fascia. Deep fascia covers the muscle, and that's what becomes infected in necrotizing fasciitis. It's infection of the muscle fascia and the subcutaneous fat. This leads to destruction or necrosis of all the tissue above the fascia, so that this tissue on the left starts to look like this cartoon on the right, where we've got all sorts of holes from necrosis of the tissue. You can have gas down in the deep tissues. That's what happens in necrotizing fasciitis. The skin can go through lots of color changes in necrotizing fasciitis. It can be red and mimic cellulitis, but it can also become purple, blue, gray, or black. In addition, because this is a deep infection, fluid can collect, and this can lead to the presence of bullae. And then finally, the skin in necrotizing fasciitis is painful and tender to the touch. Classically, the pain is out of proportion to the exam, meaning there's an apparently minor rash or injury with exquisite tenderness in the skin overlying the injury. In fact, sometimes the injury is so minor that patients don't think it's a skin process. They think they have a muscle injury because the muscle beneath the skin is so painful. Now, eventually, as necrotizing fasciitis gets worse, the pain stops and the patient develops skin anesthesia, and that's because at this point nerves have been destroyed. Crepitus can occur in necrotizing fasciitis. Crepitus is a physical exam finding. It's a crackling sound you can hear when the skin is pressed, and it's caused by gas under the skin. Remember, the infection in necrotizing fasciitis is very deep, so when bacteria produce methane and carbon dioxide, which are gases, this can lead to bubbles under the skin, and these will make a crackling sound when you press on the skin. Here's a picture of necrotizing fasciitis. Note the multiple different colors. Some areas are red, but others are pink, purple, or even black, and this would be very painful to the touch on physical exam, possibly with the presence of crepitus. Necrotizing fasciitis is often fulminant and deadly. It carries a very high mortality rate. One of the reasons for this is that the infection can spread quickly and easily along the muscle fascia. The fascia has a poor blood supply, so this allows uncontrolled spread of the bacteria. Necrotizing fasciitis requires urgent surgical debridement, and if you go into surgery, you will often be called by the emergency room to come down and evaluate patients who have rashes. What the emergency room doctor wants to know is, do you think this is necrotizing fasciitis that should go to the operating room? Obviously, you don't want to unnecessarily operate on a person who has a simple case of cellulitis. On the other hand, you don't want to send home an early case of necrotizing fasciitis because that patient can potentially die. There are two types of necrotizing fasciitis. The first type is polymicrobial. It often involves anaerobes like Bacteroides and Clostridium. In addition, it involves other bacteria like strep and staph. This occurs in patients who have some cause of immunocompromise of the skin, so in diabetics, in patients who are immunocompromised for any other reason, and also in patients with vascular disease who have poor blood flow to the skin. And this type of necrotizing fasciitis usually occurs following surgery, so a patient has a skin incision as part of a surgical operation, and following that, necrotizing fasciitis develops. The second type is usually caused by group A strep. Sometimes it's caused by staph, and this is the type that occurs in otherwise healthy people after some minor skin injury. This is the scary type where a person can have a fall and a minor injury to their skin and then develop the life-threatening infection, necrotizing fasciitis. So the classic case to know for your boards is minor skin trauma or someone who is diabetic or immunocompromised after surgery. The patient presents with redness and warmth of the skin. In the early stages, it can be confused with cellulitis. In later stages, it will look purple and black like the picture I showed you. Pain will be out of proportion to exam. There may be crepitus, and then in addition, especially in a board question, they will often describe fever or possibly hypotension as a signal that this patient has a serious and life-threatening infection. And that concludes our video on skin infections.